Bismillah ar-Rahman ar-Rahim. Now we will come to the next session. We will start by inviting Dr. Ahmed Hamimi once again to speak about fluoroscopy in the era of advanced imaging. Dr. Hamimi, اتفضل. أبو حميد تفضل.
الميكروفون السلام عليكم. بشكر قسمي واللي انا بنتمي اليه ولازم تنتمي له، لازم تحبه، ونشكر اساتذتي وزمايلي. شكرا على الدعوه الكريمه.
صوت يا احمد، صوت.
هل كده احسن؟ ماشي. المحاضره دي احنا our first lecture was about a very recent advanced imaging للfocal prosthetic therapy. This lecture is not for my colleagues, professors. This is for the residents. مين residents هنا؟ ارفعوا ايديكم. تمام. Okay. Fluoroscopy is a problem for all young generation worldwide. The young consultants in America really hates the GI rotations, the GI all day. Nobody likes it. Okay? But there is no abdominal imaging without fluoroscopy. Okay? Don't be afraid of it. It's easy, it's doable, it's nothing like a problem like anything else. It's even easier than ET and MRI. It just has some tools and you need to know. Speaking about obsolete exams that we don't do anymore. Lumbar myogram. I think I'm the last one to do a lumbar myelogram in Alexandria University. IVU. We've spent whole days doing IVUs, interpreting IVUs. My residents doesn't even know the exam. It's a relic. Nobody's using it right now. Barium for polyporators, barium enema. The art of barium enema, it was an art. It was a great art. But it's not used now for colon cancer screening. Direct angiography. I think the last case of direct angiography, I was helping Dr. Safawani, and we were doing a direct angiography. Saw it once, I don't want to see it again. Cyalogram, T-tube cholangiogram. Nobody's doing it anymore. Nobody's inserting T-tube in the United States, for example. So, I'm including the regular day work in fluoroscopy suit in University of Chicago, okay, which is everything's used. Things that exam that's so easy, but we still need it. The first exam is something called sniff test. Okay, what's the sniff test? The sniff test is to study for the diaphragmatic movement. The diaphragm has two copula, two hemidiaphragms. To answer for a question called if there's a diaphragmatic paresis or paralysis, we do something called the sniff test. It's a simple exam. The patient is standing, facing the tube, and then we ask him to breathe normally, and then breathe deeply, and then do the sniff. The idea is, if we are looking for both diaphragmatic copula moving simultaneously, there is no mediastinal shift and no paradoxical movement. This is the normal case. This is the resting. This is the deep breathing. This is another case. We can find that there is an elevation of the right diaphragmatic copula. When you let the patient take his breath, we can see that only the left diaphragmatic copula is moving. With deep breathing, we can find there's a paradoxical movement of the mediastinum. So why we repeat in the exam? The idea is when there is a diaphragmatic paresis paralysis, you need to increase the load on the diaphragm. Sometimes it doesn't appear in the regular breathing. Sometimes it has the deep breathing. Sometimes it's called the sniff test. The sniff test. So it's a plain and simple thing. There is a paradoxical movement of the diaphragm. One diaphragmatic copula, there is an ipsi or contralateral mediastinal shift. A simple procedure, but it's very important, and we have nothing else to diagnose it. Simple sniff test. OPM, oropharyngeal motion. This is not our exam, is done by the speech pathologist. And the idea is when there's a patient and the patient is going, we want to transfer into feeding, whether to solid or fluid, we need to answer for one thing, if this patient is gonna aspirate or not. The idea is, if he's gonna aspirate, if there is a problem with feeding, so we need to shift to another modality. We might need an enteric tube, we might do a gastroscopy tube or whatever. That's a very good exam, it's easy, it's done a lot. We are the one who monitor the exam, but mostly the research, the report is by the speech pathologist. Anybody knows the difference between penetration and aspiration? So penetration is when both are going the wrong tube, both are going to the larynx and trachea. If it stops at the vocal cord, that's penetration. If the aspirated material goes beyond the vocal cord, that's aspiration. So penetration, aspiration. Esophagogram, upper GI study, barium swallow. We're not doing barium meal again, but esophagogram is an integral part of our study, and the cause is there are 3 questions that nobody answers better than esophagograms. And the 3 questions are motility disorders, reflux, and hiatal hernia. No endoscopy, no CT, no MRI can answer these questions better than esophagogram. They're gonna argue with you, but trust me, there is no better thing than esophagogram. And if you're working in pediatric, you know this by heart. But definitely, and the cause why we're considering that, because now there's a treatment. There's a lot of treatment for motility disorders. There's a lot of impact on motility disorders. We might look for esophagogram and look for a cricopharyngeal indentation, something you call bar indentation. We can find a hiatal hernia. A hiatal hernia with a, so we have 2 sacs. The first sac, the upstairs sac, is the ambula or the vestibule of the esophagus, and this is the hiatal hernia. And we can argue how we can diagnose hiatal hernia, how we differentiate this from that. Now, we usually try to see if this is coming from the stomach or not, and if it has 3 folds, more than 2 folds, that's not esophagus, that's the stomach. The best picture to do is to have this thing. Both the vestibules and the hernia are visible in one study. Okay? It's easy, it's doable, and then we ask the patient to strain to see if there is influx or not. Now, this patient here has an aspiration. It goes from this tube to the other tube. Okay? This patient, on the other hand, has some motility disorder, has irregularity. To speak about motility disorders, what are the types of esophageal peristaltic movements? Primary, secondary, tertiary. 1, 2, 3. Okay, anybody knows the types of esophageal motions? So, primary and secondary are propulsive, meaning they are pushing things from upstairs, downstairs. Primary is initiated by swallowing. Secondary is an inherent property of the esophagus. It doesn't require swallowing. So both are propulsive, both are going the good way. Tertiary contraction the other way is anything else. If it's stationary, if it's refluxes, if there is an escape phenomena, that's the thing we're going to diagnose with esophagogram. That's why we need fluoroscopy, not fixed imaging. Okay, so diagnose motility disorders. This patient here on the left, you can find that there's multiple contractions. We call it tertiary contractions. You can see the video now running, and you can see that this peristaltic wave, the primary peristaltic wave, is not moving well, and instead of moving properly, it's the whole esophagus starts to contract in a abnormal pattern. Now, this patient has a bit of peculiar case in which has the hiatal hernia either sliding hernia in which the gastroesophageal junction is pulled up, usually as a consequence to reflux, and there's a rolling hernia in which the esophagogastric junction stays at its place, but then part of the stomach sweeps along the distal esophagus and appear upstairs above the diaphragm. Both are hiatal hernia, sliding and rolling. This patient in particular has both types together. The esophagogastric junction is above the diaphragm, but also there's a part of the stomach that's above the diaphragm. That's a combined type. That's the type 3 of hiatal hernia. Again, gastroesophageal junction below the diaphragm, and there's part of the stomach above, that's the rolling. The gastroesophageal junction above the diaphragm, that's the regular, the most common sliding hernia. Okay, anybody knows what that is? So what do you have here? Dilated esophagus. There is a distal. Yes. طبعا مش هتغيب عليك يا دكتور. Okay, we have distal, central, smooth narrowing of the esophagus with marked dilatation of the esophagus. Achalasia or achalasia, زي ما انتوا عايزين تقولوها. Distal, smooth, central, narrowing of the esophagus with marked dilatation of the esophagus. This is more than enough to diagnose achalasia, but there is another technique called timed swallowing, and the idea is single contrast. We examine the esophagus after 1 minute, 2 minutes, 3 minutes, and 5 minutes, and we measure the length of this relative barium cone, how much barium is still there. Some people try to measure the length, some try to measure the width. After 5 minutes, we are not expecting any barium in the esophagus or just a trace. But this case is persistent barium all through to 5 minutes, 8 minutes, sometimes afterwards. 5 minutes is more than enough. Okay? So that's the definite diagnosis of achalasia. Distal, smooth narrowing of the esophagus with dilatation of the esophagus. Now, this is a dilated esophagus, and the whole dilatation persists to the end, but this case, actually, there is no narrowing. The distal esophagus appears slightly patulous. So why is it dilated? We have to look at the chest, and we have an interstitial disease. This is a patient with scleroderma. So pseudoachalasia, in which the patient behaves as achalasia. There's dilatation of the esophagus. There is the difficulty in swallowing. But when you go to the barium, you can see it's slightly dilated. A glimpse of the scout that we're going to see in the first image. You see, this patient has interstitial disease. This patient has scleroderma. Another example of pseudoachalasia. You can see that the propulsion of the primary wave is very slow. The propulsion of the secondary wave is a very, very, very slow procedure. Okay, barium follow-through. This is a hideous exam for everybody. Nobody likes it, okay? But we're not going to try to answer anything. We're not trying to answer a very complicated things. The simple pattern is what we see. Jejunum, left upper quadrant, the plica semicircularis or the valvic inventus are coarse, thickened, close together. Ileum, maybe the left lower quadrant, the valvic inventus are less thick, more sparse. That's the normal pattern. There is no dilatation, there is no obstruction, and we sometimes call the distance between the loops, interlobar segments, are normal. That's normal, okay? We are not diagnosing malabsorption by barium follow-through. We're not diagnosing things like that, but we mainly measure the transit time. The main rule for barium follow-through is measuring time, particularly after extensive therapy, extensive surgery. We need to know how much small bowel still there. That's why we still do barium follow-through. So, this case, the whole pattern is reversed. There is an abnormal dilatation of the bowel. there's something we call flocculation of barium. The barium doesn't really appear like having this smooth pattern. Actually, this is a flocculation. The whole pattern is reversed. The jejunum doesn't appear like that. This is the malabsorption. This is the case of known Crohn's. We're not doing it to diagnose Crohn's. We're doing it just to see how much time does it require from the barium to reach the stomach, to reach the cecum. That's the main indication now for barium follow-through. So something called gastrographine's challenge. Anybody used gastrographine before? It's funny, it's still on, so everybody's using it, by the way, but we're not using it in radiology. Gastrographine is in the surgery department. And the idea is we get the gastrographine and wait till it reaches the colon and follow it by serial X-ray. The idea is that's the normal gastrographine. After 2 to 6 hours, we reach the colon, whatever part of the colon. But this patient has abnormal dilatation of the small bowel. Okay, this might be a bowel obstruction. Now we give him the gastrographine. If the gastrographine reached the colon in appropriate time or a slightly delayed time, that's what we call partial obstruction. And that's why gastrographine is important. The importance of gastrographine over other contrasts, that gastrographine is hygroscopic. It's not only a diagnostic tool, it's also a therapeutic tool. It imbibes the water, not only from the lumen, but imbibes from the water. So it decreases the mural edema, and if it could cure a partial obstruction. A patient with adhesive obstruction can be cured by the gastrography. Bariatric surgery, I leave it. I'm expecting a great lecture later on, but definitely bariatric surgery really made a great impact, on, especially on esophagogram. For bariatric surgery, we mainly use water-soluble contrast, not barium, but really with the increasing extent of bariatric surgery, I'm going to leave it to the lecture, but it really saved barium swallow. Okay, and the idea, we're not looking for motility disorder, we're looking for plain and simple question: leak or no leak. So one of the bariatric surgery is the gastric band. How to diagnose slipped or mal-positioned gastric band. We're using the phi angle, simple, plain simple. Midline line, and then a line through it. If it's with around 55, 40 to 55, we're good. Above that, that's an abnormal. Another measurement is measure from the band to the diaphragm. It's very small. If it's less than 4 centimeters, 3 centimeters, that's abnormal. If it's only 2 centimeters, that's abnormal. Okay? So that's how we're going to do the diaphragm. We don't need a CT for that. And by the way, even if CT, we need the scout. Again, this is post-fundoplication. The diagnosis here, everything, the complex, the surgical complex is all about the diaphragm. That's a failed fundoplication. That's a patient of doing an esophageal stent, and there is a leak. So the question of leak, yes or not, really saved the sphagogram, really saved our fluoroscopy unit. Before that, it was really ignored. But definitely, thanks to our surgeons, they use bariatric surgery, leak or no leak, simple question, nothing much. Water-soluble contrast, leak or no leak, AB, lateral, we're good. Doesn't require anything else. So, what's that? That's a patient after Rho and Y, and there's a leak here. What's that? What's this hyperdensity here at the midline? Chronic pancreatitis, magnetic calcifications, okay? Just in case. Now, another leak here after gastric buildup. Now, G-pouch imaging, after doing an extensive colorectal surgery, they're relieved with a pouch. Now, we have a colostomy and the patient want to be reversed. Most surgeons, if not all, cannot reverse the thing without asking the question if there is a leak from the pouch or not. Simple procedure, epilateral. We can use water-soluble contrast. If the operation is long ago, we can use barium, and it's plain and simple. Leak or no. In this patient, there's a very large leak here. All this is a leak. It doesn't look like that's all this is a leak. Now again, another leak at the at the same thing, at the anastomosis. This patient wait, give him some time to heal, and then we're going to do it again. Another big leak from the J pouch. I will not talk much about proctography. I believe MRI proctography is way better, but if you have it, it's a good technique. I really don't like it. Cystography, again, we're not using it to diagnose bladder cancer. We're not using it to diagnose probable stone. We're using it simply for leak or no leak post-operative. If you have a crazy urologist, not really close, a really eminent urologist who's doing a lot of bladder reconstruction to surgery, we need this exam. In this patient, there's a large leak here on the left side. Leak on both sides. Again, multi-compartmental leak, and you can find that the whole urinary bladder is irregular. This is after a chronic outer obstruction with multiple diverticula. Urethrogram is still working, is still done. One of the best technique. We have no alternative. Anybody has better alternative than urethrogram for imaging of urethral injuries and post-reconstructive surgery? Yeah, we don't. That's the best. So urethrogram is still done. We have a couple of more techniques. I remember the technique was taught by Dr. Zawawi. You can do it without the need of anything else. You just hold the whole urethra and pull it up. Anyhow, regardless of the technique, question is narrowing or no narrowing. That's the stricture. Usually it's at the membranous urethra, the junction between the anterior and posterior urethra. Or there's a leak. Sometimes the leak is multi-compartmental, multiple leaks. Leak or no leak, that's the best question to answer during fluoroscopy. And lastly, 1 minute. Okay, so lastly, all we know, the hysterosalpingography. Okay, we can go through the normal hysterosalpingogram. The common spleen defects is A. loculus. We should not do it. We go down, this is an arc with uterus, with some loculation on the left side, so there might be a peritubular adhesion on the left. This is the patient with a regular uterine body. Then it might be a fibroid. There is dilatation of the right fallopian tube. This is the hydrosalpinx. This is the larger hydrosalpinx. And now there is bilateral tubal adhesion. History is still working, and again, with all respect to the sonohysterogram, which is a great technique, this is the gold standard for imaging of the fallopian tube. That's why when we are doing it in our institution, they put the catheter inside the uterine body. They don't want to know about the uterine body. We know that by ultrasound, by whatever technique we're using. They want to use one question only. Fallopian tube patent or not patent? Patent, good spill, no loculations. Make sense? Thank you.